The urinalysis is considered a part of a physical exam, and it's a very old tradition to examine the urine and what are the components of urine and how do we interpret these. So we are going to go through this today. Presentation. Okay, the objectives of today's sessions are know the components of the urine and stool exam and know the normal abnormal values and how to interpret them. Overview of the urinalysis, you all know it's an ultrafiltrate of the plasma. So the substances in the plasma are filtered through the glomerulus into the kidneys, and the vital substances are reabsorbed and the toxic substances are excreted out. Glomerular filtration rate is 180 liters per day, and 90% of it is reabsorbed. These are urine samples lying in the laboratory, and you can see they are of various colors. They are labeled, ready to be processed. What do we do is this is a urine dipstick, old method which is impregnated with chemicals, and you dip in the urine and interpret it either with the color change, or now we have more accurate machines which do the urine dipstick and they are very accurate. So this is the color reading method. You dip in the urine and see if there are any changes in the color. And this is the Unisys machine, the latest machine. And this is a urine sample in the dipstick being processed in the machine, and here the specimen is registered and the results come out within a minute. And then the technician reads it, and then comes the microscopy part. So the dipstick is a chemical analysis, and then they spun the urine. They put into the centrifugation tube and run it so that the liquid portion remains on the upper side and the supernatant or sediment settles down. They take a drop from the sediment, put on the slide and examine under the microscope. What are the indications of urine examination? It's a routine screening exam, give you a lot of details about the systemic diseases, detection of urinary tract infection, used to had a good use in monitoring or diagnosing diabetes, but we know that the renal threshold is very variable, so we use blood glucose for a screening and monitoring purposes. Complications of pregnancy, in which preeclampsia with proteinuria, intravascular hemolysis with hemoglobinuria, and the screening test for primary renal disease or any systemic diseases like diabetes, hypertension, which affect the kidneys. The most important part is how to obtain a urine sample, and believe me that urine sample is not taken according to the way it should be. So there's various methods: random specimen, first morning specimens, clean catch midstream, and a catheterized patient. So the random specimen is you can take it anytime, but the disadvantage is that urine is dilute. So the best specimen, they say, is first morning specimen, in which overnight the substances, proteins, glucose, they get concentrated, and the bacteria also multiply during the night in the bladder. So this is the best specimen. Clean catch midstream specimen we'll discuss in detail when we'll discuss the urine cultures. And in catheterized specimens, the important point to remember is that don't break the system, don't make it open. So keep the system closed, disinfect the catheter with the alcohol and clamp the catheter and withdraw with the needle. Don't detach the urine bag from the Foley's catheter, because that's going to cause serious infections. This is urinalysis, 3 parts. First is the physical, which contains color, clarity, odor, specific gravity and pH, and the chemical analysis. This is the dipstick exam and urine sediment exam, in which we look under the microscope for red cells, white cells, epithelial cells, casts, bacteria, crystals, etc. Let's take the microscopic analysis. The color is important. It can tell you a lot. Normally the color of urine is because of a pigment which is urochrome, and pale urine we think that pale urine is usually when we drink too much of water, but this is not always true, because in diabetes the hyperglycosuria causes osmotic diuresis. So in that case, patient might be dehydrated, but the urine will be pale. Deeper colored urine may not always indicate concentrated urine, as pigments like bilirubin can cause deeper pigmented urine. And if the sample is allowed to stand at room temperature, the color may deepen also. So what are the various colors we can see in the urine, and what's their causes? Very pale yellow, excessive fluid intake, diabetes mellitus and insipidus because of high urine output, and use of diuretics. Dark yellow in underhydration, bilirubin, ingestion of carrots, and even drugs can do that. For example, nitrofurantoin. Orange color with bilirubin, oral anticoagulants. Red color is important because it can represent either hematuria, hemoglobinuria, or myoglobinuria. And you are all aware of that rifampin can cause red or orange urine. Beets in some patients who are predisposed or susceptible can also cause red urine. Brown urine, usually in myoglobinuria. And the green urine, it's characteristic. The Pseudomonas produces a pigment which causes green coloration of the urine. So even in the colony, when we grow it in the microbiology lab, the Pseudomonas colonies have a greenish bluish tinge. So that may be a clue that this organism may be the cause of infection. Odor. Ketonuria is important, especially your diabetic patients who are type 1, and they may have a tendency to develop ketoacidosis. Bacterial infection, the urine odor is usually very pungent, fishy and fetid type. Specific gravity, what does it mean? It means that the density of the substances, the specific gravity of water is 1. And the urine, as it contains more solutes, its specific gravity rises, and it gives us an indication of the hydration status of the patient. This is a refractometer which detects the specific gravity. 2 or 3 drops of urine are put into it, and the bottom line gives you an idea that where is the specific gravity. This specific gravity is 1.027. The causes of high and low specific gravity, like uncontrolled diabetes, it contains glucose, proteins, so it causes high specific gravity, and overhydration and diabetes insipidus cause low specific gravity. Normal urine pH is 4.5 to 8, and basically if there is an acidosis, the urine will be more acidotic, and if the patient has alkalosis, the urine will be more alkalotic. Proteins, this is important. Normally urine contains only scant amount of proteins. Small amount is low molecular, which is albumin, and the other protein we call is Tam horse fall glycoprotein, which is secreted by the distal renal tubular cells. And most of this is reabsorbed by the tubular cells, except in pathogenic conditions. Sometimes persons who do not have renal disease, they have proteinuria. Examples are after strenuous exercise, dehydration, fever, or any systemic illness. And another benign condition in young patients, we see orthostatic proteinuria, in which when the patient assumes an upright posture, the proteins spill into the urine, and when you check the urine early in the morning after he's supine whole night, the urine is negative for proteinuria. Okay, normal subjects contain less than 20 milligrams per day of albumin in the urine. And we do urine dipstick, which detects the proteins. But you can see that the dipstick detects only when the proteinuria is more than 300 to 500 milligrams per day. So it means that between 20 and 300, urine dipstick can miss. So this is called microalbuminuria, which is 30 to 300 milligrams per day, and this is important in diabetic patients and the patients who are at risk of cardiovascular disease. The preferred method is to do this urine albumin to creatinine ratio. You take a urine, check how much albumin is in there, check how much creatinine is in there, and take the ratio. And this ratio will tell you, for example, if the ratio comes like 3, it means that the patient is excreting 3 grams of proteins per day. So this is a very good test. You don't have to do the 24-hour urine for protein excretion. Then proteinuria is sometimes transient, like in fever, exercise, and sometimes it's persistent. So persistent proteinuria is indication of renal disease, and this is the indication to refer the patient to the nephrologist. You have to differentiate whether this is the glomerular proteinuria or tubular damage, not going to go in detail. And sometimes systemic disorders like multiple myeloma, in which there are plasma cell disorders, high level of immunoglobulins, which we call Bence-Jones protein, spill into the urine. The point to remember is that Dipstick is not going to pick this. So for this test, if you are suspecting your patient with renal failure, high ESR, anemia, old patient, so you have to do a protein analysis or urine protein electrophoresis for Bence-Jones proteins. Glucose, normally it is all absorbed after it is filtered through the glomerulus, but sometimes when the threshold is low, that you can see that the glucose can spill into the urine. But the most common cause is uncontrolled diabetes mellitus. Okay, ketones are important in diabetics and the patients who are having starvation or who are on a diet program who want to lose weight. So in those patients you can see ketonuria. Blood is very important because it can signify a very serious disease to your patients. So there are two types, gross hematuria and microscopic hematuria. Gross hematuria is visible, the urine color will be very red, smoky, and it will be positive for RBCs. But the other things which can cause red urine is myoglobinuria and hemoglobinuria. These are the various urines, and you can see that even a little amount of blood can cause change in the color of the urine. This is 1 per 1,000 part of the urine of blood, and you can see that the color, how the color has changed. These are the dipsticks, and you can see, for example, here second, this is the blood row, and you can see that this is positive, and as you go along, the sample has less amount of blood. Microscopic hematuria is detected on microscopic examination, and what's the normal value for hematuria, microscopic hematuria? How much red cells should contain? For males it's less than 2, and for females up to 5 RBCs per high power field. When you detect there are RBCs in the urine, one thing you have to do is whether this is a glomerular hematuria or this is extraglomerular hematuria. How you are going to tell? On urinalysis or microscopy, we see how the RBCs look. If they look like a uniform size, shape, density, this is extraglomerulus. And here you can see that the RBCs are of different density, different size, and dysmorphic as they travel along the tubules in the collecting system. So these are dysmorphic RBCs, characteristic of glomerular hematuria. What are the common causes of hematuria? In blue here you can see a circle around. These are the more common causes, and you can see that these causes are present early in the life, but cancer BPH usually represent later in the life. Hemoglobinuria can also cause red urine, and the common causes are hemolytic anemia, transfusion reactions, or in cases of extensive burns. In this case, urine dipstick will be positive for blood, but when you will do the microscopy, you will see that there are no RBCs or few RBCs. Bilirubin, urobilinogen, Dr. Arif has gone through in his evaluation of LFTs. Nitrite, what does nitrite mean? In urine there are nitrates, so if there is urine infection or bacteriuria, the bacteria act on nitrates, convert it into nitrite. So this is an indirect evidence that this patient is having a urinary tract infection. Leukocyte esterase is also a method on dipstick, which indirectly can tell you that there are neutrophils in the blood. Microscopic analysis, we check all these things under the microscope.
And the normal value for WBCs is 0 to 4 or 5 WBCs per high power field. So if the WBCs are high, the most common cause is infection. But there are other non-infectious causes like renal calculi, tumor, interstitial nephritis. Okay, and this is a slide which is giving you these multi-lobed polymorphonuclear leukocytes in the urine. Epithelial cells, they come from the renal tubular cells and denote the tubular necrosis. Okay, what is this? This is fruit pie, and the reason I have put this slide here is that why these fruits are fixed here, why they are not scattered, because this pie contains jelly-like material which contains these fruits in place. So this is the concept of casts, the urine casts. In the urine there is a protein and these proteins are called gel-like substances, and they are formed in the renal tubules and collecting ducts. And basically the major protein is dam horsefall proteins, as we discussed earlier, which is secreted into the tubules. When the cells are secreted into the tubules and there is stasis, then what happens that these cells, just like fruits in the jelly, these cells get embedded into those proteins, and then the casts form according to the shape of the tubules. This is a muddy brown cast you can see, and this is a hallmark of acute tubular necrosis seen in aminoglycoside toxicity or hypotension. These are waxy and fine granular casts. Don't go into the detail, these are the field of the micro laboratory people, but these represent the degeneration of the cellular casts. Okay, this is a biopsy of the kidney, and you can see that these are the glomeruli, and in between you can see these RBCs. So this is a process how the casts are being formed, that when there is a glomerular hematuria, these RBCs come, and when they get embedded into the tubular protein, they form casts, and then they are visible. This is a RBC casts visible in the urinalysis. This is a epithelial cell cast, and this is a white blood cell cast. White blood cell cast, if you see in the urine, it denotes that the source of white blood cells is bladder or renal parenchyma. This denotes that the white cells are coming from upper urinary tract, and this is indicative of pyelonephritis. This is a waxy cast. Okay, now crystals. In the urine you will see many crystals, and if you look under the microscope, they look like stones or gems. This is the calcium oxalate crystals usually seen in the acidic urine, and these are the uric acid crystals, very common. And these are the phosphate crystals, or we call triple phosphate, and the hallmark is they are formed in the alkaline urine. And probably a multiple choice question could be that these stones are implicated when there is infection with urea splitting organism like Proteus. So if these are the stones, then you must check for UTI secondary to the Proteus species. And these are the cystine crystals. Okay, urine culture, it's very important. Indication is basically urinary tract infection. Epithelial cells denote the tubular necrosis. They are normally present, but if they are present in excess number like epithelial cell cast, they denote some tubulo-interstitial disease. Okay, the point to remember here is that when not to do urine culture. There is one indication in urinary tract infection: a young female, healthy female who does not have any structural or functional abnormality and who comes to you with dysuria, frequency, urgency. In that case, it's an uncomplicated UTI. You can treat empirically for 3 days with antibiotic empirically. But all other indications like complications, failure to respond, recurrent infections, immunocompromised, nosocomial infections, you need to do urine cultures. Sampling is important. How to get a urine culture? High yield if collected early in the morning, and the specimen should be clean catch and midstream. Ideally, the books recommend that local disinfection should be done with a non-foaming antiseptic solution like ethyl alcohol, and then clean and dry with a sterilized gauze
so that it doesn't get mixed with the urine. And then to prevent skin decontamination, labia should be spread with fingers in females and foreskin retracted in uncircumcised males. And first voided specimen should be discarded and midstream specimen should be collected. And the sample should be sent immediately to the laboratory. This immediately should be underlined, because if you allow the urine to stand, the bacteria will multiply and give you a false high count. This is in microbiology lab. The specimen is being registered. This is the loop which is dipped into the urine and then inoculated onto the agar and put into the incubator and then read after 24 to 48 hours, and you can see the growth of the microorganisms. Then the sensitivity tests are applied to see they are sensitive to which antibiotics. What's the definition of positive urine culture? One thing to remember is that if there are more than 100,000 colonies or more than 10 raised to the power 5 colonies, then this is significant. And the reason we have put this, because during sample collection there is contamination. So there will be bacteria due to contamination, but if they are more than this count, then contamination is less likely. Okay, well, this picture is not my choice. Dr. Nasser used his influence and put this slide here. So this is the stool analysis, and here is the sample being taken, and with a drop of normal saline onto the slide, the sample is mixed, and then a cover slip is put and examined under the microscope. Okay. The point to remember here is that the small ribbon-like stools are seen when there is obstruction in the colon or the elasticity of colon is compromised, and this is usually seen with colon growths like colon cancer. You will get handouts so you can go through this later on. Microscopic analysis, we saw all these. The most important is leukocytes and the parasites. Fecal leukocytes, they are important because diarrhea is very common. So how we differentiate diarrhea is with the positive fecal leukocytes and those diarrhea which don't have a positive fecal leukocytes. So the ones who have positive fecal leukocytes, they are invasive diarrhea, and the most common organisms are Salmonella, Shigella, Yersinia, and invasive E. coli. More than 3 or more leukocytes per high power field are abnormal. And these are the organisms in which you won't see fecal leukocytes. Someone might argue that why not Entamoeba histolytica? The reason is that because it destroys the white cells. It's an invasive disease, it does cause dysentery, but usually it destroys the white cell. So in mild to moderate disease you won't see, but if the patient is having a severe invasive disease, you might see fecal leukocyte count. This is a stool stain with methylene blue showing leukocytes, fecal leukocytes. Qualitative fat you can detect in the stools, and if high, you can suspect some malabsorption syndrome. Meat fibers, if there is pancreatic insufficiency, you can see meat fibers too. And parasites, the point to remember here is that the samples should be taken which contain blood and mucus, and the stool should be sent fresh because the cysts, they get destroyed in time. And these are the common examples, various parasites. This is Trichuris trichura, Entamoeba histolytica. This is a cyst of Giardia, and this is a hookworm ovum. And this is Diphyllobothrium ascaris eggs. Other important point is occult blood, and this is a screening test in old patients for colon cancer. And when you are ordering occult blood, make sure that your patient is not having these things, because these can give false positive result. So let the patient have no laxatives and have the meat-free diet, not taking these medicines, and after 2 to 3 days then order fecal occult blood testing. Collection of stool specimen, you can go through the handouts. Stool culture, basically we culture these organisms. And that's the end of the presentation. Thank you for everything.